Hello, this is Norma. I'm going to be presenting my patient, initials of MD. This is a 65-year-old Hispanic female with a past medical history significant for hypertension, non-insulin dependent diabetes, dyslipidemia, and an MI in 2004. She presented to the emergency room with the chief complaint of chest pain. Onset was this morning. The duration of symptoms were constant. The location is generalized. Radiating pain is to the left shoulder. Character of symptoms are sharp. The degree at present is moderate. Associated symptoms are shortness of breath and fatigue. The exacerbating factor is none. The relieving factor is none. The patient reports that she has experienced similar pain in 2004 when she was hospitalized and was diagnosed with a heart attack. She reports that she was taken to the cath lab at that time and had 2 stents placed. She is unfamiliar of what vessels the stents were placed in. She reports that she's been following up with a cardiologist ever since. She also states that she was in the kitchen this morning making breakfast for her and her husband when she felt a sudden onset of chest pain. She also felt shortness of breath. Her husband immediately called 911 and had the patient brought to the hospital. The patient is a physical therapist assistant, retired 2 years ago. She does live at home with her husband of 35 years, and the youngest daughter of 26 years does presently live with them. She denies feeling stressed or depressed, denies any feelings of wanting to hurt herself or others, denies smoking any tobacco or illicit drug use. She does report having a 1 to 2 alcoholic beverage history. On occasion, she states that it's mostly on the holidays. She does have allergies to tramadol, which she reports having hives and itching, and allergies to penicillin. She reports difficulty breathing and tongue swelling. Medications that the patient is currently taking is metoprolol tartrate, 25 milligrams PO daily, lisinopril, 20 milligrams PO daily, simvastatin, 20 milligrams PO daily, and aspirin, 81 milligrams PO daily. On review of systems, the patient was positive for shortness of breath, chest pain, and fatigability. Negatives, the patient was negative for fever, chills, weight loss, or weight gain. All other systems were negative and normal. On exam, the patient's initial vital signs in the emergency department, she had a temperature of 98.2 Fahrenheit. This was oral. She had a pulse of 93 beats per minute, respiration of 20 breaths per minute, blood pressure of 119 over 85 millimeters mercury. She was saturating 96% on room air, and the patient had a BMI of 26. Pertinent labs, the patient had a hemoglobin of 15.1 and hematocrit of 45. Sodium was 125, potassium of 3, troponin I elevated at 1.5, magnesium at a 1.7, and a BNP of 350. The patient's chest x-ray showed regular lungs are clear, no pleural effusion, no pneumothorax, cardiac silhouette of normal size, no atherosclerotic calcifications. EKG impression, bradycardia with type 1 AV block and nonspecific ST segment changes. On exam, the patient appears to be in moderate distress. Her heart sounds were regular in rate and rhythm without murmurs, rubs, or gallops. She does have no peripheral edema. Peripheral pulses were present at a +2 and no JVD. She was moving air well. Lungs are clear to auscultation bilaterally. She was saturating 96% on room air. Her bowel sounds were present in all 4 quadrants. Abdomen was soft, non-tender, without rebound tenderness regarding. She denied any CVA tenderness. She was alert and oriented ×4. All cranial nerves 2 through 12 grossly intact. My assessment is that of a 65-year-old Hispanic female with a past medical history of hypertension, non-insulin dependent diabetes, dyslipidemia, and an MI, who presented to the ER with the chief complaint of chest pain radiating to her left shoulder, onset this morning. The patient's problem list: non-STEMI, hypertension, non-insulin dependent diabetes, dyslipidemia, and a previous MI. My plan was to initiate fluid supportive therapy with 0.9% normal saline at a rate of 70 mLs per hour. Start the patient on a heparin drip, weight-based, to maintain a therapeutic PTT between 60 to 80 seconds to prevent more blood clots from forming. If the patient has no relief of her chest pain with morphine or nitroglycerin tablets sublingual, I will start a nitroglycerin drip to keep the patient chest pain free. I would start her at 5 to 10 micrograms per minute. I would reconcile the patient's home medications to assure the patient is taking her beta blocker, ACE inhibitor, and her statin due to the previous MI and current non-STEMI. I would add an antiplatelet and consider initiating an anticoagulant. I would admit the patient to the coronary care unit and consult the cardiologist, either the one that she's seeing or the one on call, depending if her cardiologist does come to the hospital. I would order vital sign checks Q15 to include a temperature. I would repeat the troponin I and PTT every 6 hours. I would order a cardiac diet and then keep the patient NPO after midnight in the event of the patient's possibility of going to cath lab again. I would start DVT prophylaxis care with SCDs. I would hold the Lovenox since the patient will be on a heparin drip. The priority in treating a STEMI or a heart attack is to open the artery quickly, saving as much heart muscle as possible. Treatment options include the PCI. This means medication and stenting with a clot busting medication and a coronary artery bypass graft surgery, which is a CABG, depending on how extensive the patient's problems would be. This would all be inviting an interdisciplinary collaboration with the cardiologist, the hospitalist, to see what we feel would be best for the patient. My disposition for the patient would be the patient would be admitted to the coronary critical care unit. The cardiologist has already been consulted. Prepare the cath lab team in the event of a stat left heart catheterization for the patient, and just keep the patient informed as much as possible.